ASAM Criteria, treatment criteria for addictive, substance-related, and co-occurring conditions, then and now. See, it all started with the Cleveland Criteria. It was developed at the request of the Northern Ohio Chemical Dependency Treatment Directors Association. The Cleveland Criteria were designed by a team of consultants who coordinated by the Chemical Abuse Treatment Outcome Registry. Members of the steering committee that guided the project represented treatment programs and other interested organizations in Northern Ohio. Then came the NAATP criteria. In a parallel effort, a work group composed of providers and consultants, coordinated by Richard Weedman, MSW, FACTA of Healthcare Network Incorporated, used all criteria sets available at the time to produce the National Association of Addiction Treatment Providers, or NAATP, patient placement criteria. These criteria were used by approximately 210 publicly and privately funded addiction treatment programs to enhance their internal utilization review and case management systems, as well as to guide their clinical decision-making processes. Then came the NAATP ASAM collaboration. Progress was made by these initial efforts, eventually led to another project in which NAATP and the American Society of Addiction Medicine, otherwise known as ASAM, recruited a representative group of addiction experts to develop adult and adolescent criteria based on the Cleveland criteria and the NAATP criteria. The project resulted in the identification and description of 4 levels of care, which were differentiated from each other by the following characteristics. 1, degree of direct medical management provided. 2, structural safety and security provided. 3, intensity of treatment services provided. This project also identified and described 6 assessment dimensions that could be used to differentiate patient needs for services across the 4 levels of care. The result of these efforts were compiled to create the patient placement criteria for the treatment of psychoactive substance use disorders, which was published by the American Society of Addiction Medicine in 1991. Boom. Then Coalition for National Clinical Criteria came into place, recognizing the need to broaden stakeholder participation in developing patient placement criteria. ASAM convened a meeting of providers, payers, managed care professionals, and policymakers the same year its initial patient placement criteria was published. And out of this session emerged a consensus that the field ought to work toward one national set of criteria which could be accepted by employers, purchasers, and providers of care, both in the public and private sector. This group helped identify the desirable characteristics of clinical criteria guidelines. Current and future directions. The point in history held by the current edition of the ASAM criteria will no doubt be an interesting one. It's arguably quite appropriate for this edition to focus on addiction associated with substance use as its subtle claims, because except for gambling disorder, there is not a clear evidence base regarding the true epidemiology of non-substance abuse associated addiction. The current edition takes steps towards this with the inclusion of a section on gambling disorder, as articulated in the DSM-5, while other cases of addiction such as sex addiction, internet addiction, or exercise addiction still await a consensus on definitions, criteria, prevalence, and incidence that has yet to emerge. The guiding principles of the ASAM criteria. Beginning with the first edition of the ASAM's criteria, certain foundational concepts have continued through this edition and will no doubt serve as the foundation for any future developments. Similar to its predecessors, The following guiding principles serve as the basis for all content within the ASAM criteria. Moving from one-dimensional to multi-dimensional assessment. Moving from program-driven to clinically driven and outcomes-driven treatment. Moving from fixed length of service to variable length of service. Moving from a limited number of discrete levels of care to a broad and flexible continuum of care. Identifying adolescent-specific needs. Clarifying the goals of treatment. Moving away from using previous treatment failure as a mission prerequisite. Moving toward an interdisciplinary team approach to care. Clarifying the role of the physician, focusing on treatment outcomes, engaging with informed consent, clarifying medical necessity, and incorporating ASAM's definition of addiction. Moving from one-dimensional to multi-dimensional assessment. The ASAM criteria continues to encourage moving away from treatment based on diagnosis alone, seeing a diagnosis as a sufficient justification for entering a certain modality or intensity of treatment, but moving towards treatment that is holistic and able to address multiple needs. A diversity of clinical offerings and intensities reflects the diversity of patients who may have needs in a number of clinical and functional dimensions. The criteria's 6 assessment dimensions were specified in order to address this guiding principle. These dimensions are introduced in Chapter 3, Intake and Assessment. Moving from program-driven to clinically driven and outcomes-driven treatment. Rather than focusing on placement in a program, often with a fixed length of stay, the ASAM criteria supports individualized, person-centered treatment that is responsible to the patient's specific needs and progress in treatment. Moving from fixed length of service to variable length of service. Outcomes research in addiction treatment has not yet provided a scientific basis for determining precise lengths of stay for optimal results. Thus, addiction treatment professionals recognize that length of stay must be individualized based on the severity of the patient's illness and the patient's level of functioning at the point of service entry, as well as based on their response to treatment, progress, and outcomes. But at the same time, research does show a positive correlation between longer participation in the continuum of care and better outcomes. Moving from a limited number of discrete levels of care to a broad and flexible continuum of care. The criteria build on the original concept that levels of care represent intensities of service along a continuum, each of which may be provided in a variety of program types, including those that offer more than one level of care and that serve multiple populations. Treatment is delivered across a continuum of service that reflect the varying severity of illnesses treated and the intensity of services required. Referral to a specific level of care must be based on the careful assessment of the patient with an alcohol, tobacco, and or other substance use disorder and or a gambling disorder. A primary goal underlying the criteria presented here is for the patient to be placed in the most appropriate level of care. For both clinical and financial reasons, the preferable level of care is that which is the least intensive while still meeting treatment objectives and providing safety and security for the patient. Moreover, while the levels of care are presented as discrete ranks, in reality, they represent benchmarks or points along a continuum of treatment services that could be harnessed in a variety of ways, depending on the patient's needs and responses. A patient may begin at a required level and move to a more or less intensive level of care, depending on his or her individual needs. Identifying adolescent-specific needs. Adolescents who use alcohol, tobacco, and or other drugs, or who manifest pathological patterns of gambling, differ significantly from adults who do the same. While substance use disorders in adolescents and adults may have common biosocial elements of etiology, they are different in many aspects of their expression and treatment. Adolescence affords a unique opportunity to modify risk factors that are still active and not yet complete in their influence on development. Adolescents must be approached differently from adults because of differences in their stages of emotional, cognitive, physical, social, and moral development. Examples of these fundamental developmental issues include the extremely potent influences of the adolescent's interactions with family and peers, the expected immaturity of most adolescents' independent living skills, and the fact that some amount of testing limits is a normative developmental task of adolescence. Most adolescents do not develop classical physical dependence or well-defined withdrawal symptoms, although the epidemic of youth opioid addiction is an exception, nor do they exhibit the psychological deterioration seen in many adults suffering from substance-related disorders because of the shorter duration of their exposure to alcohol, tobacco, and or other drugs. Nevertheless, they are vulnerable to the drugs and the full range of emotional, behavioral, familial, and cognitive manifestation of addiction. In fact, adolescents may be more susceptible than adults to the functioning, impairing impact of the use of substances, even in the absence of physiological withdrawal. The progression from casual use to high severity substance use disorders can be more rapid in adolescents than in adults. Also, adolescents typically demonstrate a higher degree of co-occurring psychopathology, which may not remit with abstinence. These limitations severely inhibit the ability of adolescents to arrest their addiction and address essential developmental tasks without external assistance and supports. Adolescents' use of substances frequently impairs their emotional and intellectual growth. Substance use can limit a young person's ability to complete the maturational task of adolescence, which involve personal relationships and social skills, identity formation, individuation, development of a full repertoire of coping skills, education, employment, and family role responsibilities. Because substance use alters the way in which individuals approach and experience interpersonal interactions, the substance use in adolescent psychological and social development are compromised, as is the formation of a strong, positive self-identity. Clarifying the goals. We got to clarify the goals of treatment. Treatment that is tailored to the needs of the individual, guided by an individualized treatment plan, and developed in consultation with the patient, is helpful in establishing a therapeutic alliance and therefore contributing significantly to treatment outcomes. The individualized plan should be based on a comprehensive biopsychosocial assessment of the patient and, when possible, a comprehensive evaluation of the family as well. Patient-centered care includes documentation showing where and how the treatment plan identifies problems or priorities, such as obstacles to recovery or knowledge or skill deficits that inhibit achievement of the patient's overall reason for seeking treatment. Includes strengths, skills, and resources such as coping strategies to deal with negative effects and stressors, successful exercise routines, medications that may have been effective, positive social supports, and a strong connection to a source of spiritual support. States goals that guide realistic, measurable, achievable, and short-term resolution of priorities or reduction of the symptoms or problems. Lists methods or strategies that identify the personal actions of the patient and the treatment services to be provided by staff, the site of those services, staff responsible for delivering treatment, and a timetable for follow-through with the treatment plan that promotes accountability. And is written so as to facilitate measurement of progress. As with other disease processes, length of service should be linked directly to the patient's response to treatment. For example, attainment of the treatment goals and degree of resolution regarding the identified clinical problems or priorities. The goals of intervention and treatment include safe and comfortable withdrawal management, motivational enhancement to identify the need for recovery, the attainment of skills to maintain abstinence, etc. Determine the methods, intensity, frequency, and types of services provided. The clinician's decision to prescribe a type of service and subsequent discharge or transfer of a patient from a level of care needs to be based on how the treatment and its duration will not only influence the resolution of dysfunction, but also positively alter the prognosis for long-term recovery and outcome for that individual patient. Moving away from using previous treatment failure as an admission prerequisite. Although another concern that guided the development of this publication is the concept of treatment failure. This term has been used by some reimbursement or managed care organizations as a prerequisite for approving admission to a more intensive level of care. For example, air quote, failure in outpatient treatment as a prerequisite for admission to inpatient treatment. In fact, the requirement that a person fail first in outpatient treatment before inpatient treatment is approved is no more rational than treating every patient in an inpatient program for using a fixed length of stay for all. It also does not recognize the obvious parallels between addictive behaviors and other chronic diseases such as diabetes or hypertension. For example, failure of outpatient treatment is not a prerequisite for acute inpatient admission for diabetic ketoacidosis or hypertension crisis. A treatment failure approach potentially puts the patient at risk because it delays a more appropriate level of treatment and potentially increases healthcare costs if restricting the appropriate level of treatment allows the addictive disorder to progress. Moving toward an interdisciplinary team approach to care. The ASAM Criteria maintains and builds on ASAM's previous efforts to respond to ongoing changes and needs within the special field of addiction treatment. It also recognizes that with addiction treatment and health reform, more services to persons with addiction will be delivered outside of a separate and separately funded specialty treatment system for addiction and will be delivered inside systems for addiction of general medical and general behavioral health settings. Addiction care has always been built around services involving interdisciplinary teams of professionals, including and sometimes led by physicians. With health reform, addiction care as well as mental health care will increasingly be delivered by clinicians working in interdisciplinary teams and not only addiction professionals, but also general medical care professionals. The expansion of the patient-centered healthcare home model for delivering comprehensive, integrated care for patients and families, including behavioral health care, mental health and substance abuse related care, will mean that persons making decisions about how and where to offer treatment to persons with addiction and related conditions will need to envision new treatment models and settings. Such models and settings will be unfamiliar to many clinicians who have been practicing in and who likely receive their clinical training in specialty settings for addiction care. They will need to incorporate new skills of greater collaboration with other non-addiction treatment professionals and inclusion of peers and peer supports. Clarifying the role of the physician. Due to their prevalence, substance use and addictive disorders are health conditions that have a significant impact. Physicians are essential part of the healthcare delivery system for addiction, as well as for all acute and chronic medical and surgical conditions. Increasingly, teams of professionals are working in a coordinated fashion to deliver health care. While mental health care has been offered through interdisciplinary teams for decades, especially in public sector settings, general medical care has only recently developed models to involve a range of health social services, rehabilitation, and other professionals to manage chronic diseases. The patient-centered healthcare home model is a prominent example of this. Focusing on treatment outcomes. Increasing payments to practitioners and programs will be based on the service provided, but on the outcomes, not on the service provided, but on the outcomes achieved. We've been saying this for a long time, and yet it has yet to manifest. But we're moving towards that, believe it. Treatment services and reimbursement based on patient engagement and outcomes is consistent with trends in disease and illness management, especially when conducted in real time during the treatment experience, as with the management of hypertension or diabetes. With these chronic illnesses, changes to the treatment plan are based on treatment outcomes and tracked by real-time measurement at every visit. While evidence-based practices contribute to positive outcomes in treatment, the quality of the therapeutic alliance and the degree to which hope for recovery is conveyed to the patient contribute even more to the outcome. Engaging with informed consent. Treatment adherence and outcomes are enhanced by patient collaboration and shared decision-making. To engage people in treatment and recovery, person-centered services encompass clear information to patients. Certain sections of the ASAM criteria mention directly or draw upon the concept of informed consent. Healthcare requires informed consent, indicating that the adult, adolescent, legal guardian, and/or family member has been made aware of the proposed modalities of treatment, the risks and benefits of such treatment, appropriate alternative treatment modalities, and the risk of treatment versus no treatment. Clarifying medical necessity. Some sections of the ASAM criteria may mention or draw upon the term of medical necessity. This concept is central to judgment for third-party payers and managed care organizations to determine appropriateness of care. Because substance use, addictive and mental health disorders are biopsychosocial in etiology and expression, treatment and care management are most effective if they, too, are biopsychosocial. The 6 assessment dimensions identified in the ASAM criteria encompass all pertinent biopsychosocial aspects of addiction and mental health that determine the severity of the patient's illness and level of function. For these reasons, the ASAM criteria asserts that medical necessity should pertain to necessary care for biopsychosocial severity and is defined by the extent and severity of problems in all 6 multidimensional assessment areas of the patient. It should not be restricted to acute care and narrow medical concerns, such as severity or withdrawal risk or Dimension 1, acuity of physical health needs, as in Dimension 2, or Dimension 3, the psychiatric issues such as imminent suicidality. Rather, medical necessity encompasses all 6 assessment dimensions, so that a more holistic concept should be necessity of care, clinical necessity, or clinical appropriateness. Incorporating ASAM's definition of addiction. When it was first published in 1991, ASAM's patient placement criteria was considered a guide for linking severity of illness to intensity of care, specifically when the health condition was a psychoactive substance use disorder. This first edition was published only 2 years after ASAM adopted its current name as a National Medical Specialty Society, the American Society of Addiction Medicine, and at the time, bringing together physicians interested in treating alcoholism with physicians interested in treating opioid and other drug addiction, along with physicians interested in treating nicotine addiction, was revolutionary in its own way. But still, the focus of this new society was on the prevention and treatment of, and medical education and research about specific forms of chemical dependency. Conditions such as pathological gambling were well known, but over the years, ASAM repeatedly declined to redefine itself as an organization that would address non-substance related addiction in its policies, education, or advocacy activities. ASAM chose not to identify its mission as including behavioral addiction. Eventually, however, advancements in neuroscience help ASAM member physicians and organizational leaders recognize the biomedical processes in the brain underlying the outward behavioral manifestations of persons with addiction. The ASAM definition of addiction, the short version. Addiction is a primary chronic disease of brain reward, motivation, memory, and related circuitry. Dysfunction in these circuits leads to characteristic biological, psychological, social, and spiritual manifestations. This is reflected in an individual pathologically pursuing reward and or relief by substance use and other behaviors. Addiction is characterized by the inability to consistently abstain, impairment in behavioral control, craving, diminished recognition of significant problems with one's behaviors and interpersonal relationships, and a dysfunctional emotional response. Like other chronic diseases, addiction often involves cycles of relapse and remission. Without treatment or engagement in recovery activities, addiction is progressive and can result in disability or premature death. What's new in the ASAM criteria? While relying on the same principles that have guided previous editions, the ASAM criteria now expands on prior understanding and applications to serve a wider and more diverse population. This broader population includes people with addiction who are older adults, parents with children, and also those working in safety-sensitive occupations. The current edition also branches out to explore addiction services within criminal justice settings. In addition, new information has been included to assist in applying the ASAM criteria in managed care, in utilization management, and in the context of mental health and addiction parity and federal health care reform. Finally, additional sections have been added to this edition to respond to the request of users of the criteria, clinicians, care managers, and public and private section payers to make information more applicable to the real world in which providers deliver care and payers and third parties authorize and manage care. Other keylights of this new edition include, but are not limited to, synchronization with the ASAM criteria software, such that the definitions and specifications in this information, levels of care and admissions decision rules serve as their reference manual for the ASAM criteria software developed with the support of SAMHSA. Combining adult and adolescent treatment information in order to show overarching alignment with the guiding principles and applications of the ASAM criteria. At the same time, the ASAM criteria continues to distinguish between adult and adolescent population and presents separate diagnostic and dimensional admission criteria within each level of care. Incorporation of the latest understanding of co-occurring disorders capability, formerly termed dual diagnosis capability, and what might better be termed complexity capability, to acknowledge the range of services needs beyond just addiction and mental health treatment. This need for services with substance use disorders to be assessed and treated for co-occurring infectious diseases is but one clear example of this concept. Programs and practitioners increasingly understand the need for trauma-informed care and primary health, behavioral health integration as core features of all addiction treatment programs. As the treatment field has learned more about the complexities of the people we serve, it increasingly is becoming more trauma-informed and responsive to the needs of people with co-occurring mental and substance use disorders. Services that are co-occurring, capable, or enhanced, and complexity capable are described within this particular edition. Inclusion of the conceptual framework of recovery-oriented systems of care to facilitate understanding of addiction treatment services within a recovery-oriented chronic disease management continuum, rather than as repeated and disconnected acute episodes of treatment for the acute complications of addiction and or repeated and disconnected readmissions to addiction or mental health programs that employ rigid lengths of stay into which patients are placed. And further expansion on the role of the physician. The role of physicians within interdisciplinary teams in various levels of care deserves attention, which work group members, authors, and editors have attempted to recognize and articulate. There are physicians working in more traditional medical practices, such as outpatient clinic settings, and are not necessarily in interdisciplinary teams. It is hoped that in their own offices, They will increasingly meet patients' needs through the use of pharmacotherapies as well as psychosocial therapies, as these are indicated in individual cases. Most changes occurring in mental health settings where psychiatrists and other mental health clinicians are screening for and treating addiction and are more open to co-occurring disorders treatment. ASAM is committed through the publication of this and future editions of the ASAM Criteria to be relevant to an ever-evolving healthcare service delivery landscape. Updated diagnostic admission criteria for the levels of care is to be consistent with the American Psychiatric Association's 2013 publication of the Diagnostic and Statistical Manual of Mental Disorders, better known as DSM-5. There's a new section on gambling disorder that is consistent with ASAM's definition of addiction, asserting that the pathological pursuit of reward or relief can involve not just the case of psychoactive substances, but also the engagement in certain behaviors. The inclusion of a gambling disorder section also reflects shifts in the latest edition of the Diagnostic and Statistical Manual of Mental Health Disorders, DSM-5, which includes gambling disorder in the Substance Use and Addictive Disorders chapter. There's a new section on tobacco use disorder. It reflects a decision to address the treatment field's inconsistencies in and even ambivalence about viewing this condition as similar to alcohol and other substance use disorders. There's an updated opioid treatment section to incorporate new advances named opioid treatment services addressing opioid antagonistic pharmacotherapy in addition to opioid agonistic psychopharmacotherapy. Previous editions and supplements of ASAM's criteria had described care offered in what this edition is naming opioid treatment programs. There's updates to better assess, understand, and provide services for all 6 ASAM criteria dimensions to reflect current science and research. There's revised terminology, which reflects contemporary usage and a strength-based, recovery-oriented, trauma-informed, and culturally competent approach. There's a reformatted level of care numbers. There's a user-friendly format. And then there's new terminology being used. The individuals served in treatment are now most often referred to as individual, person, participant, or patient, and these are used interchangeably in this ASAM. The book title and concept is now called the ASAM Criteria. Terms such as dual diagnosis and dual disorders are now described in the spectrum of co-occurring disorders or conditions. Detoxification services are referred in this edition as withdrawal management. Opioid maintenance therapy is now discussed as opioid treatment programs and office-based opioid treatment within opioid treatment services. Level 3.3, clinically managed medium intensity residential treatment, is now level 3.3, clinically managed publication-specific high intensity residential services.